Okay, for those of you who have just joined us and didn't hear my little spiel as I was kind of just jumping on in there a few minutes ago, I've been an oncology nurse since 1985. I've been a nurse since 1984. Didn't really plan on being an oncology nurse. Didn't have that in my plan when I got out of nursing school. However, within 15 to 18 months, I was working full-time in a medical oncology office, and I have not worked with another group of patients, or I've always worked with cancer patients from some avenues since then, and it has given me so many blessings that it is very difficult for me to really tell you all the blessings that God has bestowed on me through the work with cancer patients and their families. For those of you out there who are survivors or who are caregivers, you're an amazing group of people, and you have so much to give and so much to teach others that you are truly a blessing in ways that I know you don't realize. Tonight's talk, we're going to be talking primarily about cancer and its impact on women. There are many things about cancer and cancer treatment that we talk about, but there are a few things that we don't talk about, and we're going to spend some time on those things tonight because those are very, very important topics. And sometimes the ones that aren't talked about are the ones that we have the most questions on, of course. We're going to start by talking about a few definitions, talking about the three top cancers in women in the United States. We're going to talk about some factors that contribute to cancer having such an impact other than just the obvious. And then we're going to talk about fertility issues, sexual health, and gene testing. And I am recovering from a respiratory cold. I feel 110% better, but I do have this little nagging cough. So I apologize ahead of time if I have to stop and have a few coughs there. Definitions. As we know, cancer is an uncontrolled of immature cell growth that forms a mass or tumor. Our bodies were designed, and it is just mind-boggling to me. It's one of the conversations I want to have with the Lord, is how our bodies know on such a molecular level that a colon cell knows how long it should grow and then when it should stop growing. Excuse me, because our colon is how it's supposed to be. Same thing with lung cancer, same thing with lung cells, same thing with liver cells. You know, they grow, they make these wonderful organs, and then they know to stop, and then they die off and more grow. But what happens with cancer is that when cells divide, they divide immaturely and do not get to a mature state, and then they just keep dividing. It's like they don't know how to stop, and then you have this mass and this tumor to grow. Cancer treatments have one goal, and that is to cure or remove the cancer from our body. Now, research, we hear a lot about research and our advances that have been made with cancer treatment have to do with research. The research focuses on finding a cure by really enhancing and expanding the treatment options that we have, rediscovering new ones, but also decreasing the side effects of what the current cancer treatments inflict on the body. Especially chemotherapy, because it is a systemic drugs that go in your body. Cancer chemotherapy, besides the targeted therapy, will affect good cells and bad cells. can't really distinguish between the two. Your really traditional chemotherapy regimens, and that's why we have such difficult side effects, is because the really good cells are being affected as well. So research is really trying to look at these cancer cells and see what is on the surface of these cells that are different than the good normal cells, so that drugs can be developed that will kind of be like a magnet and just go to attach themselves to the bad cells and not the good cells. Therefore, we're killing the cancer but not causing such horrific side effects from damaging good cells as well. So that's our little overview, and that's going to be important to remember when later on we talk a little bit about gene testing. Excuse me. So the top three, whoops, a little sensitive there. The top three cancers for women in the United States is breast cancer, along with the gynecological cancers, lung cancer, and colon cancer. Now that fourth bullet says skin cancer is the most prevalent of all cancers for both men and women, ranging from basal cell to melanoma. But what a lot of, because those basal cells are very prominent, you can go to your family practitioner and say, oh, you have a little skin cancer there on your face, I'm just going to, take that off, because it is very superficial. There are lots of those out there, and we see a lot of those, and you may have family members that, oh, we're going to have 2 of these little basal cells taken off. But those are still considered a skin cancer. But what we, when you kind of take those basal cells out of the equation, the top 3 cancers for women in the United States are breast, lung, and colorectal cancers. But whether, when you have cancer, whether it is the most prevalent one and in that category or not, all cancers have a tremendous impact on your body, on your family, in many different ways. So it's, it is the cancer generally that we're going to talk about, and not so much specific cancers. All cancers treatments have similarities as to the negative side effects and the impact that they impose on the body. So you have, we generally have a some contributing factors that we see for cancer to have an impact on women. And one of those is age. And since I have had, I'm not going to tell you how old I am, but I have had my 50th birthday, and I really didn't realize how often age comes up. But seems like every time you turn around, this is a contributing factor as to how old we are getting. And so age is in this category as well. Then it's the type of chemotherapy agents that are involved. That also has to do with, for those of you who are survivors, you may have heard your oncologist say, well, we need to get a biopsy and we need to see what the results of the biopsy are when they come back. And that is because once they look at those cells under the microscope, it helps them to determine which chemotherapy agents will typically are the most effective in treating that kind of cancer. And some of these chemotherapy agents may be a pill, maybe they are given IV. It just depends on the type of chemotherapy agent that you'll be receiving, as well as the dosages of the chemotherapy and the radiation regimens that are required. Another contributing factor is the extent of the surgery. Because as we know, even with all of the research and we find different drugs and different things to treat cancer with, there are still 3 main arms of treatment, and that's chemotherapy, radiation therapy, and surgery. So the extent of the surgery, whether you have With breast cancer, say a lumpectomy versus having a mastectomy, that has a different impact on your body, as well as if you have colon cancer and you having a colon resection and then you have a scar versus ending up with a colostomy that you have to learn to deal with for the rest of your life. So you have a lot of different contributing factors that really play a huge impact on cancer, on women, excuse me. Now, there are familiar conversations that we have, most commonly discussed side effects. The nausea, which over the years has really been able to manage better. Some of you may have been taking Zofran or Amanda prior to your treatment or during to your treatment. One of fatigue, we talk a lot about fatigue. That is an overwhelming, or can be an overwhelming side effect that is very difficult to manage at different times. You have heard a lot about Livestrong and the benefits of the Livestrong program, because what we have found is that one of the best ways, or most effective way to combat fatigue is through exercise to maintain muscle mass. Because if we are very sedentary, we know that our muscle mass can decrease very quickly. We have found patients in the hospital when they've been very sick, especially the elderly, and they come in the hospital and they're in the bed for 3 or 4 days. One of their biggest difficulties, once we've got, whether they have bronchitis or pneumonia, may be better, but they are so extremely weak because of the muscle mass and how their bodies have just so quickly not able to keep up with activity because they have been so inactive. So sometimes it sounds so strange to say, well, I know you're very tired and you have fatigue, but you need to keep moving. But it is so very true. The other thing we hear a lot about is pain, and I know that there are some that have really become very concerned about what we hear about the opioid epidemic in the news in our country, which is a very significant problem. However, these opioids, when used appropriately for oncologic pain, are very, very effective, and they're very, very important drugs. So your oncologist is and if you have a palliative physician, they are very versed in how to order these medications to make sure, what I like to call, they find your right recipe, because what we want you to be able to do is for you to be managing your pain and your pain not be managing you. So so that is something that we try very hard to talk about. Hair loss is one that is very drug dependent, depending on which drug you have. Not all chemotherapy causes hair loss, so it's really drug dependent. Depression is something that can easily slip in while treatment is going on. And then, of course, there's finances that can have such a huge impact on the whole family unit that is very difficult to manage. But how many of you may have heard the most recent report out of the American Cancer Society just this month? That is a report on the data from 1991 to 2012, which really in the medical field, 4 or 5 years, we're usually that far behind as far as data. But it talked about the cancer death rate has decreased by 23% in the last 21 years. That is phenomenal. So that is something that is very exciting in our world, and we can contribute that a lot to a lot of people who have stopped smoking, or our efforts to get people not to smoke, because smoking has such an impact and has been linked to just about any cancer you can think of, but also research and how these the cancers have responded to research. But also what that tells us is that sometimes with having a lot more people, a lot more survivors out there, we have more people who are learning to deal with the long-term side effects that have that they experience, and that really oftentimes will not go away from having their cancer treatment. So that is why it's so important that we talk about survivorship and that we talk about how to help patients and families and caregivers to manage these side effects and to really work with survivors, but to also listen to survivors. We need to hear from you as well to tell us what are the things that you have found that works to manage your side effects, and what hasn't worked as well. So one of the things that we are going to talk about first is fertility. And when we talk about fertility and sexual health and intimate relationships, we also need to consider that there are very young adult cancer patients as well, or teens who have gone through cancer and are now young adults. So we need to talk about what is it like being single and dating and being a cancer survivor, and then the gene testing. So fertility first. According to the National Comprehensive Cancer Network, or NCCN, this is a national organization of oncologists for physicians that really set the national guidelines for our for treatment and for the medical community. But it is very important that when possible, the most important time to have the conversation about fertility when treatment is discussed. Doctors do not often spend much time on this subject, so it is important that we ask the questions. And it may be that the person that you talk to in the office about side effects may be your physician, but oftentimes it's your chemotherapy nurse. It's the one that's giving you the treatments, or who is you've gotten your information to sign your consent from your physician, but as the nurse is getting you to actually sign the consent to witness your signature, a lot of times that's when questions come out, and that's when questions you may be a little bit more comfortable asking questions of your nurse, because you have that relationship oftentimes, and you see your nurse sometimes more often than you see your physician. But some questions to consider is, will my treatment affect my ability to have children in the future? Are there steps I can take before beginning treatment to preserve my fertility? Will the treatment affect my monthly menstrual cycles and the age in which I develop menopause? Can I take my birth control pills while on treatment? How long should I wait after treatment before getting pregnant? These are all very pointed questions that can really spark a conversation about fertility and the importance of knowing what is going to happen to your body, what can you expect. As we all know, even though if there's something that's going to occur with our bodies that may not be positive, if we know that it may happen, it's not quite as frightening. It's still not fun, and it still can be frightening. But if you know ahead of time, my periods might stop. I may be getting hot flashes. Those are things to consider. And if you're sexually active during treatment, it is very important, and if you're in the childbearing age, to have the conversation about birth control. We know that gynecological cancers can be very hormone driven, and birth control pills is something that can be very have a very negative impact on that. So if you've always used birth control pills as your form of birth control, then that is a very important conversation to have with your physician and the nurse to find a different acceptable form of birth control during that time. So fertility preservation. Medications are given to stimulate ovary production. Now, of course, if you have ovarian cancer, then this is a whole different conversation to have with your physician. So right now, our conversation is around preserving fertility, and if that is an option for you. So medications are given to stimulate ovary production. Eggs are then harvested and fertilized, and then fertilized eggs may be frozen and to be implanted in the future. Freezing unfertilized eggs, according to the National Comprehensive Cancer Network, is still in an investigational stage. They do not know a whole lot about how the eggs respond to that, whereas with sperm, those can be frozen alone. If you really want to have a lot of information about that, one of the resources that you can look at on your own is called Fertile Hope, and it is an initiative from the Live Strong program, and it is recommended by the American Cancer Society, and they do reference this support option on their website. So I want us to, you know, there's lots of information out there on the web, and it's very easy to be kind of taken off in different directions. So look for things that are recommended by or suggested by really good trusted sites like the American Cancer Society, because you want these people, you want to use these people who have already done the investigations for you. It's really going to save you a lot of time and a lot of stress by really focusing in on really good trusted sites. So we have any questions at this point about fertility at this time? I am not a fertility expert. One of the things that we really want you to be able to do is to feel comfortable having the conversation with your physician or your nurse. There are fertility experts that you can be that can be consulted and can be sent to, whether you are in a large cancer center that may already have these experts on staff, or whether you're in a community cancer environment that your physician can call and arrange for you to have an appointment at the larger facility for the experts on conceiving. And there are experts that are available to help women carry babies. You know, that depending on what kind of treatment you've had and how your uterus has responded, the inside lining of your uterus can change. The expandability of your uterus, you know, it's this big old muscle, can change, and so some uteruses have a little difficulty expanding as the baby grows, but there are physicians that are trained to work and to help women carry babies as well. So don't be afraid to ask these questions if you have concerns about this. Okay. Sexual health. God created man and woman. In Genesis 2:24 through 25, therefore a man leaves his father and mother and clings to his wife, and they become one flesh. And the man and his wife were both naked and were not ashamed. We are designed to be relational. We like having relationships with each other, and this is not something that was by accident. God designed every part of our body, and it's okay to talk about every part of our body. And remember that sexual health involves a person's body, involves a person's mind, involves a person's behavior, and it involves a person's relationship and how we view ourselves. The impact of cancer that has on our bodies may leave scars. You end up with ostomies that you hadn't had before that are coming out of that flat tummy that you used to have. And our bodies change. They don't feel the same the way that they used to feel. And it really can have an impact on us overall. Our mind and our emotional state can really be changed because we worry about our mates and what they think of us and exactly what these scars, the impact of these scars, and we get kind of fearful thinking about, can I be intimate again? And then all of that affects our behavior. There are times when, if we're experiencing a lot of pain, whether it may be just when we get up and walk across the room, then we tend to not get up and walk across the room as often because we know that if I get up and do that, I'm going to have more pain. It's called incidence pain. It's pain directly related to an activity. So our behavior can change if we have uncontrolled pain that is associated with intimate acts. So our behavior can change. And all of these things that we talk about have to affect our relationships, unfortunately. And so we're going to talk about a few of those things and how we do view ourselves. Whoops. Get the button clicking right. How can cancer treatments affect a woman's sex life? It can introduce premenopause, or sometimes called perimenopause. Which means that you can have irregular periods, or your periods can stop. Hot flashes. I actually, not telling you how old I am, but we had 6 inches of snow yesterday when I went to work, and I was carrying in a fan to set in my cubicle. I know it was cold outside. Everybody was just, had all their little sweaters and everything on, and I brought a fan in. Well, sometimes you just have to. Those hot flashes can be really tough, as well as night sweats. You can have a lower libido, just a decrease in your sexual desire, mood swings, weight gain, difficulty concentrating, vaginal dryness, breast tenderness, and sleep disorders. Having trouble going to sleep or having trouble staying asleep as our hormones rage and they fluctuate so much. I do think that we underestimate the need that our bodies have to get adequate sleep. I'm amazed at people who can go on just a few hours sleep, because our bodies do need that. That's how they rejuvenate. That's how they heal. And that's how we can get emotional rest as well. So sleep is very important. But during menopause times and premenopause times, it may be very difficult to get really really good sleep. Mood swings, changes in the vaginal lining, increased dryness. And then we talk about surgery a little bit. Surgery usually takes something away, which may be a tumor. It may be a section of the colon. It may be a lobe of the lung. It may be breast tissue, whether a mastectomy or whether just a lumpectomy. But surgery can also leave things behind, like ostomies and scars and indentions where you never had them before, and pain. So you have a combination of a lot of these things that, and if we look back on all of that, from just the simple thing of vaginal dryness to having trying to be intimate with an ostomy now, all of these things can really affect a woman's sex life. So things to, whoops, I think that was, yeah, so let's talk about some of these things. What do we do about some of these things? Well, of course, you know, I would tend to think just the example I've given, a fan is a good thing. You know, having a cooler environment is very, very important. There are many lubrications that are on the market these days, but it is very important that we address the dryness that occurs, because that can really cause some not just pain, it can cause some frustration when you're intimate, but also we don't want any of the linings of the vagina to become really irritated and could start some bleeding. So we need to learn about relaxation techniques. It's very important that we learn how to relax muscles during all of your treatment, whether you may be having radiation or different treatments in the pelvic area. Your muscles can become very tight without you even knowing it. And when they get very tight like that, it is very difficult to get them to relax. So it takes a concerted effort, and practicing relaxation techniques can be very helpful for those pelvic muscles. Music, candles, romantic novels, antidepressants, ointments for the scars. You know, I think that I have heard women talk so much about their body image. And sometimes just making sure the lighting is a little bit different, a little bit turned down a little bit more, not putting so much attention on your body sometimes can be very helpful for some women. Along with managing these ostomy appliances, one of the interesting things that we have with ostomy appliances now is that they do come in different sizes. These bags now are different colors. You can get very, very small ones that you can place on your stoma and the appliance, and put it in a different direction so that it is not so prominent on your belly during times of intimacy. There are times when you may want to wear clothing, a little teddy or something, to cover up some of a part of your body that you're just not as comfortable with anymore. So there are different options around that to use, but try, you know, we want things to be the way they used to be. And sometimes coming to grips with exploring a new way of doing things that may not be the way we did it before, but having that conversation with your spouse to really understand that, you know, our lives have changed. It is not the way it used to be. You know, our intimate life is not going to be the way it used to be. But that doesn't mean that we can't still have an intimate life to it may be just something different. And that's why I want to talk about the power of touch. It is extremely important that we do not underestimate the power of simple touch. Would like to give you an example of a woman. This is a real story. She had progressed in her cancer journey to where she had to wear oxygen all the time. That was just something that she could do most anything, but climbing stairs and the need to have oxygen was just something that she had to incorporate into her daily life. Her bedroom was upstairs, and her husband still slept upstairs. And they were really starting to feel the strain within their relationship. Now, they have been married for a very long time, but they could really start feeling the strain within their relationship. And one of the things that they started doing is that although she always slept on the sofa because that was the place that she could get that she could rest better, is that they started a new routine at night. And the thing that they did was that her husband would take lotion and he would rub her back. Every night he would slowly rub her back. And then he would lie on the sofa with her and hold her until she went to sleep. And once she went to sleep, then he would get up and go upstairs and sleep the rest of their night. And that change in having that daily touching really transformed their relationship, and it was something that brought them back together. So don't ever underestimate the power of touch. No matter where within the cancer journey that you are, touch is always can be acceptable, and it can be something that can be done. Maintaining or even increasing the amount of touch giving and received during treatment. Rediscover what your body finds comfortable and pleasurable at this time in your cancer journey. Maybe what traditionally was comfortable for you in the past is not comfortable for you anymore. And so we really have to try different and new things. So explore that. And remember, a little laughter in the bedroom is not a bad thing. So when should a person not have sex? This is a conversation that you really need to have with your physician, because everybody's body is different. Everybody is responding to treatments in different ways, and there's really not any clear-cut answers to this. There are some kind of overlying guidelines that we kind of go by, and one of those things is recovering from surgery. Now, whether it's surgery that you have had because of cancer or not, but when your body is healing, your surgeon, just like he says, you know, you don't drive for 2 weeks, you don't go back to work for 2 weeks, but sometimes he may not say if you can have sex or not, and you need to ask that question. Now, some of them can. Your gynecologist, they're usually pretty good about having that conversation with you. But some of the other surgeons maybe not. But it is a very important question to ask, and don't be hesitant in asking that. And if your immune system is really compromised, one of the things that we have to think about is that even when we're healthy, we as women, when we have sex, we are more prone to having urinary tract infections. You know, you may have heard from your gynecologist, you know, you need to be sure and get up and urinate after you have sex to kind of make sure to decrease your chances of having a urinary tract infection. But if your immune system is compromised, then you really do increase your risk of having urinary tract infections or contracting other infections. So it's very, we another area to consider. And you may experience bleeding during sex and if you have cancers affecting the urinary tract. So keep that line of communication open with your physician and with your spouse, because it's very important for your mate to be involved in what's going on in your body, to know everything about you, to keep that relationship strong in all areas. A disease such as cancer, but generally inherited mutations are thought to play a role in about 5 to 10% of all cancers. This information you can read more specifically about from the National Cancer Institute. But I think one of the ways that we can talk about this a little bit more is kind of to go through a few frequently asked questions. Does someone who inherits a cancer predisposing mutation always get cancer? And the answer is no. What genetic tests are available for cancer risk? There are many. For example, with breast cancer, there's the BRCA or the BRCA1 or the BRCA2 for breast cancer. There are genes that detect Lynch syndrome to predisposing of colon cancer. So there are many, many different cancers, but who should be considered for gene testing? And physicians who consider gene testing generally look for a combination of the following: cancer that was diagnosed at a very young age, several close relatives that have the same cancer, that cancer that has developed in a set of paired organs like 2 kidneys, 2 breasts, unusual cases of a specific type like breast cancer in men, and the results of these gene testing is what can help guide medical decisions for the future. Now, again, if you go through gene testing, it's usually done through blood or tissue, and the results are either positive or negative. There's not a little bit or maybe not enough. It's either positive or negative, one or the other. And that is just saying that the laboratory did see mutations or did not see mutations on that. And if it is positive, then it generally means that your risk for getting cancer may be higher. If it is negative, then your risk, according to that test and the information they have, your risk of getting cancer is the same as the general population of getting cancer. And resources around this have to, are really major cancer centers have physicians that concentrate and do research on gene testing. They also have genetic counselors that are very, very trained in having these conversations and doing all of this background information and taking your histories and looking at the different cancers, and it is a very involved process. Interestingly enough, it's very expensive, as you can imagine. Some insurance companies do pay for it, some do not, and a lot of those look at whether you are at very high risk or in a high risk category as to whether or not they will pay for that gene testing or not. So they look back at that list. The Mayo Clinic has put out a lot of information about genetic testing. There's also information at the American Cancer Society and the National Cancer Institute. Let's see. So I think we're kind of pushing the time there a little bit. If you have any questions you want to put out there, I think if my clock is right, we're getting, I've got 8:24. If you have questions, we can take those now. I hope that this information has been helpful. It is not easy information or subjects to often have a conversation about, but I do think that if you are having relationship issues, or if any of these topics are close to home to you, that you will consider having those conversations and really looking at investigating ways that you can renew your intimacy when at all possible.
So Sarah, I've got a quick question while other people are maybe thinking of their own. So you put this together for us for kind of a women's view, cancer women view. In your experience, in your nurse livelihood, what are the splits of women with cancer versus males with cancer? Do you know the percentages, or is it just not a deal?
No, as far as you're talking about the top cancers that they have?
Yeah, or just even more general. I was just wondering, men versus women. Are women at more risk?
Well, men, of course, prostate cancer is a cancer that has really been diagnosed, and that has really had an increase, and part of that has to do with the screening and the PSA screening, and there's controversy around that now. Are we doing too many of those? And because sometimes those PSA tests may be false positive, or we're doing more procedures than we really need to do. Lung cancer, ironically, has decreased a lot in men and increased in women, and the thought behind that has to do some with that women actually got on the bandwagon of smoking a little bit later than men did, and have not stopped as soon as some men have, and so we're seeing the result of some of that. You know, smoking is the thing that has been linked to so many different cancers, including bladder cancer. There are smoking residue and cells that have been found in bladder when they do bladder biopsies and stuff. So it is just really not just a respiratory type effect that can have on our bodies. So the lung cancer and the prostate cancer are two of the main cancers for men right now.
Got it. And the lineage, it's in those sibling, parent, child, those kinds of disclosures to your doctor, I'm told, are some of the most important. So
absolutely, absolutely. The history behind that. And those are the things that when you go for gene testing, they are going to ask way back on both sides. Your paternal grandparents, your maternal grandparents, the questions are very, very extent. But it's really interesting talking to patients who have gone through some gene testing, that the things that they investigate, that they found out that their aunt and their mother or their uncle or something, they didn't even know they had until they started asking questions. Well, I didn't know he had that cancer. I didn't know he had this. So it really is important to have that history and to really learn about our backgrounds. Okay, Fairview, why is gene testing not covered by insurance? Would that not help with early detection? Gene testing really does not tell you whether or not you have cancer or not, so it's not considered one of the screening tests. It is one for risk. So insurance companies have not really gotten on board with that. I can see as more research comes down the pipe that they may do that, but I do think that it could eventually help with early detection to know who should make sure that they're screening more often, or maybe at an earlier age. It is unfortunate that that is not covered, but that is something that I think will should change as more research is done. Let's see. If you are on Medicare, if you will pay for the gene testing because it had been done with no charge. Oh. After my third cancer, my insurance covered my genetic testing. There you go. You know, one of the things with that is, you know, we talk about who should get, who do we consider, should consider getting gene tested. And let's see if I can find cancer, if it's diagnosed at a young age, if several close relatives have the same cancer. I thought this was interesting. One of the things that they look at for gene testing is that if a cancer is found in twin organs, like cancer in both breasts, cancer in both kidneys at the same time that develop, they will look at that. Had biopsies multiple times. No, please. Let's see. What's up with the new guidelines for breast exams? They are looking at, you know, there's different testing going on for mammographies now. Some women can have basic mammographies, and then there's 3D mammographies as well. There is a real debate about when mammography should start. There are still some guidelines that are talking about age 40, when we know that we have breast cancer patients that are in their 20s. So it really is, I think, one of the gene testings and early detection is really going to change that now. I have, to be honest, I have not looked to see exactly when the most recent age with that is, but the controversy is that the age for women to have mammographies is much later than what the oncology, a lot of the oncology world is seeing, and that has really caused a real discussion within especially the nursing oncology world. If women have had any indication or had any lumps that have been detected, the guidelines have been that then that is when it's started yearly or after the age of 50. I know that my insurance company, there's that age thing again, after age 50 sends me my reminder about getting my mammographies done. I did have a questionable mammography, and since then I get one yearly for that. It's really interesting how the testing and the screening, how we say how important it is, and then there's controversies over paying of insurance companies and when they will start paying for women to have these mammographies, but age 40 personally I think is very late to start having mammographies. 3D mammography is available and helps detect cancer 2 to 5 times years earlier. We do, it is important to ask your center or where you go if they do have 3D mammography. I know in just our small community here, our community hospital has just put in a 3D mammography machine, so it is becoming the standard of care to have that available to use, and I do think the insurance companies are going to have to get on board very, very quickly with that. It says that most insurance companies ask for more copay from their patients to have the 3D mammography. One of the other things that, in spite of having, okay, Mary Lou says that I've been told that I only need testing every 2 years now because of age, in spite of having to have a lumpectomy years prior. Yeah, I really struggle. I'll be very honest with all of y'all. I really struggle with some of those. We don't want to over test, but I think just like she's talking about when she's had to have a lumpectomy, I don't think that that is over testing. It is really a national discussion, and I know within my oncology nursing society that I'm a member of, this is something that has really been a very hot topic within our nursing oncology society. Why are there not guidelines for post breast cancer follow-up, but rather just wait for symptoms? Doesn't that kind of fly in the face of early detection being the key? I think you have a very good point. I think that's why we really should really look at standing up and asking these very tough questions. And I know that the American Cancer Society, along with the Oncology Nursing Society, is really trying to ask those questions. I see Karen's head, so I think she is getting ready to jump in here.
I am, Sarah, but this has just been extraordinary. I just really cannot thank you enough for just your openness and your honestness, and of course your wisdom. You just have great wisdom, darling, and so thank you for sharing so much. I'm going to go ahead and close this in prayer, but Sarah has not got anywhere to run off to because she's all snowed in. So if anybody would like to stay around and continue the conversation and ask her more questions, I want to welcome you to be able to do that. But if you take a moment with me and bow your heads, I will pray us out of here tonight, ladies and gentlemen. Lord, I thank you so much. I thank you so much for Sarah, and I thank you so much for the gift of this technology that we can end up sharing her with so many people and in so many places tonight. I ask for you just to be able to continue to take our hearts, to be able to help people that are coping with cancer, and to be able to give us your words in your hands and your feet as we do so. We lift all of this up in your glorious Son's name.
Amen. Thanks, everyone.
You guys are the best. I appreciate it.